Yes.
Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Agarwal. 27th meeting, 855th COVID interaction. Today, I'm going to make certain things. I want to present what's happening in the last 1 week in the treatment and in the vaccine scenario. And then we will have a matter for open for discussion. I want to show some slides. So if you see here, 3 drug trials have been halted in last 1 week. Johnson & Johnson study, there is a study pause, but not a regulatory hold. That means this was a voluntary halt by Johnson & Johnson on a phase 3 trial of 60,000 people vaccine called J&J 7846735 vaccine. Single shot vaccine, which I think is not a correct approach. The reason being single shot vaccine from my point of view may not be the right approach, because we have seen after a natural infection 30% people are not developing antibodies. This was a human adenovirus AD26, non-replicative AD26 virus combined with spike protein of coronavirus. This is the same technology used in Ebola. They have developed one unexplained illness, so the vaccine trial is on hold. Earlier, AstraZeneca with Oxford University, their virus chimpanzee adenovirus OX1 was put on hold because of 2 cases of transverse myelitis. Now something important here. The trial is continuing in UK, India, South Africa, and Brazil. See, the trial is continuing in UK, India, South Africa, and Brazil. However, the trials are on hold in US. So that's a matter of concern. Here comes some ethical principles also, that the country of origin of the vaccine, their regulators are not convinced that this vaccine is good, but other countries, the trials are continuing. This is a matter where I would like Russell to comment later on. And then Eli Lilly and company halted phase 3 trial named Active 3, which is a antibody drug LY-CoV. LY is Eli Lilly, CO is coronavirus 555 in hospitalized patients. And they said it produced a different clinical situation unexplained. They are not talking about side effect. They say patient developed a different clinical situation. And this trial is with or without remdesivir. All these 3 trials are on hold. And now WHO has said that remdesivir, hydroxychloroquine, lopinavir with ritonavir, and interferon B1 subcutaneously does not reduce mortality. So from the picture, hydroxychloroquine is gone, remdesivir is going, lopinavir has already gone, interferon beta 1 is gone. Now, what was this trial? This is a solidarity trial. 11,266 patients, 30 countries, 405 hospitals. So real good picture. 2,750 received remdesivir, 954 received hydroxychloroquine, 1,411 received lopinavir, 651 received interferon, 1,412 they received interferon, 4,088 received placebo. Initially, hydroxychloroquine was pulled up, then lopinavir, ritonavir was pulled out, hydroxychloroquine was pulled out, and now they say that interferon and remdesivir also does not make any significant change. The patients were randomized equally between whichever study drugs were locally available. The intent to treat primary analysis was mortality, ventilator use, and length of hospital stay. And they say little or no effect of these drugs on the outcome at 28 days. The compliance was 95%. There was only 2 to 6% crossover. Total number of deaths were 1, 2, 5, 3. And all the groups, the deaths were insignificant change. The p-value 0.11, 0.97, 0.23, and 0.50. There was no significant improvement. No study drug definitely reduced mortality in this particular, whether it was ventilation or initiation of ventilation or hospital duration. Now, out of these drugs, many of these drugs have been given emergency use authorization by governments of many countries, like remdesivir in India. Now, that will come into a question now. It did not look into the use. Now, however, this drug, this trial was not, they did not talk about spread in the community or COVID prevention. Obviously, it was a antibody, it was a treatment trial. Now the WHO says that after these trials, now we are looking for monoclonal antibodies and immunomodulators and some newer antiviral drugs. So as on today, we are back to situation 0. Monoclonal antibodies, Eli Lilly has halted. Immunomodulators and some new antiviral drugs will now be tested. So I come back to the basics. And the basics are very clear that this is an inflammatory virus. So antivirals probably has no role. Virus is not killing people. What is killing people basically is the inflammation. None of these drugs are anti-inflammatory. Therefore, if you detect the patient early, in the first 3 to 5 days, you may be able to take care of the inflammation. So therefore, the basic analysis, what I have done in the last couple of days is that all these researches are going down. We are coming back to the basics. The basic test is CRP, and the basic drug is dexamethasone given early, along with the basic drug is dexamethasone and oral anticoagulation. Now, over for discussion. Dr. Marthanda Pillai.
Good morning. Thank you, KK. It's a very good briefing as to what is happening in COVID management, and all these documents are already become in the public domain. And what I feel is that these drugs are expensive. There are a lot of side effects, and if the research says that it is not of any good, then probably we can avoid these drugs. And what is more important is early detection of hypoxia. We in Kerala categorize these patients into 3 groups. One is category A, where patients are positive, non-symptomatic, asymptomatic, or have mild symptoms. And they are asked to be at home in isolation. If they don't have facilities, then they can be in a hospital. And category B is those with fever, sore throat, and moderate symptoms, where again, symptomatic treatment under supervision in a hospital is required. And third, of course, is category C, where patients have symptoms, particularly respiratory symptoms, and have comorbidities, and they are elderly. So if we are able to pick up those patients who are born to deteriorate, particularly in the category A, normally don't deteriorate. But category B, at least a good percentage go on to category C or with more symptoms requiring ventilation and other supportive treatment. And if we can, by measuring the amount of hypoxia by oximeter, if they have, say, 90 to 93% or below, then they need intensive care management. So early picking up of patients for supportive treatment for anti-inflammatory drugs, anticoagulants, and other mode of treatment, definitely I feel the mortality can be reduced. Thank you.
I'd like to raise this point with Dr. Russell that why should a vaccine trial be halted in America, continuing in other countries, knowing very well that 2 cases of transverse myelitis are not a usual occurrence?
Well, I mean, I would presume that the FDA is the regulatory. They are probably holding back for whatever reason. Although they say that it might be the UK regulatory body might accept it by December. So I'm not too clear why they've stopped in only USA. It does make sense. Yeah, it doesn't make sense, isn't it? It's allowed in UK, India, and several other countries. So your thoughts about that, KK? Why?
I personally feel is that the only way India, Brazil, other countries, they might have allowed it only on the reason that multiple sclerosis is not that common in India, and it is much more common in America. So therefore, they may not have had a transverse myelitis due to vaccine, but because of multiple sclerosis. With that,
what about UK? They're allowing it in UK, isn't it?
UK, yes, but that's the reason I'm putting it down today, because now UK also has allowed. If a regulatory body of US is not allowing in their own country, the vaccine of USA not allowed in USA, and other countries are allowing it, it's a question which is an ethical issue.
Yes, that's exactly what but again, it's probably a European, AstraZeneca is again European, and the Oxford is a European, so the headquarters of that study appears to be in Europe, that group, you see.
Whatever it is, it's a matter, because what I'm only trying to say is that
the ethical
whatever is coming at a very high level is getting blocked. Because Eli Lilly drug in a terminal stages, nothing is coming out to be safe. So this virus is behaving unpredictable.
What about the Pfizer one, Pfizer vaccine, KK? They're using some other technique, isn't it, with that company? They're combined with one of those biotechs.
Pfizer one is a DNA vaccine. It is a DNA plasmid vaccine with the RNA into it. So that's also, we are watching for that. That's a DNA vaccine. They are still on the way. See, let me come back to the vaccines, different types of vaccines. One is a killed vaccine. Now, killed vaccine, out of 5 vaccines which have been given permission to sell or use, 3 belongs to killed vaccine. Killed vaccine means you carry no risk. You kill the virus and you use. But these vaccines may not be very effective, and they may have to be given repeatedly. Single dose will not. We have seen with a live virus, antibodies are not produced in 30%. Therefore, will killed vaccine produce antibodies effectively? We don't know. But the killed vaccine is on the the killed vaccines, 3 vaccines which have already been approved belongs to killed vaccine. And India is working on a killed vaccine. ICMR is working on a killed vaccine. Live attenuated vaccine, nobody is working. Then people are working on a vector vaccines, and 2 of the vector vaccines now have been halted. So whether a vector vaccine will be a useful way of putting a vaccine, we don't know, because both the vaccine of Oxford used a chimpanzee and Johnson & Johnson used a adenovirus 26 as a vaccine. Sputnik also, a Russian vaccine also is an adenovirus. So 2 more viruses which are on, so 2 more vaccines which are on commercially used are vector vaccines, and both of them are human adenovirus vaccine and not the chimpanzee human adenovirus vaccine. But that vaccine also is easy to make, but we don't know whether that will be effective or not, because humans do get adenoviruses in our body. Will they cross-react the immunity? We don't know. So as on today, a real good vaccine, we don't know when it will be available. That's one. Number 2 is the very fact 30% of us are not making antibiotics, not building antibodies. So single dose vaccines, will they be effective? We don't know. So Johnson & Johnson was a single dose vaccine. So I have all my doubt that a single dose vaccine will work. Dr. Kasar Sajjad. Dr. Sajjad, you want to say something? Dr. Sajjad? See, the more and more I'm studying, I'm convinced in my mind that...
Hello.
Yes, Dr. Sajjad.
Okay. Thank you very much. Good morning, everybody. Actually, I have joined late, so I just want to know. I just heard the last few words of Mr. President. I just want to know that you said it's an inflammatory disease. So in the beginning, if a patient comes to us and say that he is running fever from the last 1 or 2 days, so what we have to do now, what we are doing is we are not prescribing any antibiotic or any anti-inflammatory drugs. Even just we advise paracetamol just to watch and just record your temperature. So if it is an inflammatory disease, so can't we start the antibiotic in the beginning so that the disease cannot be deteriorate? What is your suggestion?
So let me put it down in simple language. So first of all, virus enters my body. So I do not allow the virus to enter my body. Can I kill it in the air? The answer is no.
Yes.
Can I kill it on the surface? The answer is yes. Can I not allow my virus to enter my body? The answer is must. So now once the virus has entered my body, it will enter either through the nose or through the mouth or through the eyes. If it enters through the nose, then I block the virus there by improving my nasociliary movements. There comes the role of nasal wash, steam, then you can have nasal oils, nasal spray with povidone iodine. That's what comes a role. When the virus enters my nose, if it goes upward, it causes loss of smell. If it goes downward, it causes pharyngitis. Once the virus has entered into the pharynx, it may stay there or it may go down into the alveoli in the pneumocyte 2 cells. Now, when the virus enters my cell, it identifies a ACE2 receptor And from the virus, it is RBM, receptor binding domain. So the receptor binding domain part of the virus gets attached to the lock of the ACE2. And then there comes fusion protein, which fuses the cell membrane of the virus with the membrane of my cell, and the RNA is released in my body. So I can block that process. So I can block that process of the surface. So I can block RBM. So some vaccines are coming to block the RBM. Some vaccines are coming to block the spike protein where RBM is present. Then some medicines now are working on fusion protein. They will not allow the fusion of the viral protein, virus cell to have a membrane to membrane fusion they will allow. Once the fusion has happened, or the RNA enters inside my body. Now that RNA is very cunning RNA. It will not use any of its own. It only gives directions. It takes control of my cytoplasm in my body, and it starts using my photocopier machine, my proofreading system to generate its own copies. Their first requirement is the enzyme called RDRP, that is called RNA dependent RNA polymerase. So if I can block RDRP, and the drugs are remdesivir and favipiravir, then I come back to various enzymes which are required for formation, replication of the virus are called proteases. So I can have drugs to act on those proteases. As on today, work is going on that. And then the virus starts replicating. So all these actions can happen at this level. Vaccine or a drug can happen at this level. Now, once the viruses have started replicating in my body, they enter into the pneumocyte 2 cells. They enter into pneumocyte 2 cells in the lungs, and they produce tissue necrosis, tumor necrosis factor alpha. So they produces tumor necrosis factor alpha, which is the main component of the process. TNF alpha produces fever. So here we need a TNF blocker. So if we have a TNF blocker, which acts by PLAV2 to cause inflammation, which is phospholipase A, PLVA, to PLA2. So if you can block that by steroid, you can block the process. So TNF alpha, which is tumor necrosis factor alpha, you can block here by steroid. Now, once there is no blocking, then these macrophages in the lungs will produce interleukin 6. They will produce interleukin 6, interleukin 1 beta, and they will produce interleukin 8. Interleukin 8 will attract the polymorphs, so you can block that by interleukin 8 inhibitors. Interleukin 1A will produce high inflammation. You can block that by PLA1 inhibitors, or you can use interleukin 6 once it is increased. It goes to the brain, crosses blood-brain barrier, induces fever. Interleukin 6 orders the liver to produce CRP and fibrinogen. So here comes CRP. So either you block the IL-6 against steroids, or you have an antibody against IL-6, which is tocilizumab. Or so these are the ways where various things are available. So at this moment, the cheapest drug is steroid, reduces tumor necrosis factor alpha, and also reduces interleukin 6. And the clinical parameter is rise in CRP on day 3 and day 5. If there is a doubling of CRP between day 3 and day 5, you know the body is in crisis. CRP is not supposed to rise in viral infections. CRP will invariably rise in bacterial infections. So our clinical parameter is between day 3 and day 5. If you can see CRP doubling, a test which costs hardly anything, and at that particular moment you shoot steroid, that's the answer. Now, because I say it is an inflammatory process, whether you kill virus or not has no value. Killing of the virus will stop progression of the disease, communication of the disease to others. But killing of the virus will not kill the anti-inflammatory response. Inflammation once started will carry on. That is not viral dose dependent. That is cytokines release dependent. So what is happening is antivirals may reduce your communication to others. That means infectiousness, but it may not kill the inflammation. So therefore, giving antibiotics, all other drugs which we give to reduce the viral load, because ICMR document very clearly says that viral load has nothing to do with severity of the illness. Virus load has to do with infectiousness. So once inflammation has started, virus load has nothing to do, and there the action comes is of steroids. So today I've just invited Professor Jailal. Can you open your, he is going to take over as our national president in December. Professor Jailal. So I thought of inviting him here. Dr. Jailal.
Yeah,
So,
sir, just a minute. Sir, thank you very much, sir, for calling.
so congratulations on behalf of Simao. So we
Thank
thought
you.
of congratulating you. Therefore, I said you come over. So, so Dr. Jailal, welcome to our Simao meetings. We expect you to come here also till till next year, September, when I hand it over to the Taiwan group. So today we are talking about the pathogenesis of the virus. So Alvin has also joined. So Alvin, so you know everybody, Dr. Jailal?
Dr. Jailal, congratulations. He is part of the UNESCO. He one of the UNESCO head.
Yes, I know, he's the boss of UNESCO in India.
And our
No,
beloved
no. In
leader,
his
Bhakan
own.
Reply sir is there.
Yes.
Kausir is from
Dr.
Pakistan, and then
Dr. Jay, yes, Dr. Jailal, I'm Dr. Kaisar Sajjad, Secretary General, Pakistan Medical Association.
Yeah.
Congratulations to you for a new responsibility. I hope that through your participation in CIMO, we can have a more information regarding the medical community.
Yes, it's my pleasure, sir. Definitely, I will be with that, sir.
Alvin is our from Hong Kong. He's the treasurer of finance head of CIMAR.
It's nice to
So
meet you, sir.
Jailal is going to take over as the president IMA end of the year. Alvin. So, so Dr. Sajjad, am I clear in my what I told?
Yes, but one thing more I would like to ask, how can you know that this virus is in the body through nose or eyes in the beginning? How
Oh, no.
you know?
We don't know. We don't know. We don't know.
Yes.
But the only
Yes.
thing we know is that if it is nasal origin, then definitely there will be a loss of smell. Because, because the olfactory bulb is present higher up in the nasopharynx, not in the lower down. So from oropharynx to go to olfactory bulb can happen, but we say is that if it is a nasal COVID, more chances of smell loss. That's all.
No, what I would like to know that I have so many patients in the beginning and few patients nowadays that only one symptom that they cannot smell, the loss of smell. So this is absolutely clear. Then I treat accordingly. But if patient comes to me and just say that I have running fever from the last 2 days, it comes for 1 hour, 9900, and then goes after taking any paracetamol something. Then it's come again after in the evening. So how can we proceed? So either we just
so I'll go to the classification. So I'll tell you what we decided in CIMAO earlier. We said in current pandemic, loss of smell, loss of taste is equivalent to RT-PCR test by itself. Okay. Number 2, if the patient has fever, cough, sore throat, breathlessness, loose motions, any 2 symptoms, we will say this is suspected COVID. Number 3, if the patient has headache, patient has lower abdominal pain, nausea, vomiting, ear pain, fatigue, extreme degree of weakness, pain in the limbs lower than knee joint, any 3 points will say it's COVID. So now we are saying any 3 unusual symptoms will mean it is COVID. That's what the definition is. Loss of smell doesn't require any other parameter. But apart from loss of smell and loss of taste, if there are 3 parameters of COVID-like illness, we will consider them as COVID. Low-grade fever today, we know that low-grade fever used to be TB, but now we say low-grade fever is COVID. There is no other condition which gives you low-grade fever. So COVID is very easy to diagnose nowadays. Now what is happening is people are diagnosing COVID, then they are waiting for RT-PCR. RT-PCR doesn't come. Day 5, you have lost. Day 3 is the sign of inflammation. Remember, there are primary cytokine wave and a primary cytokine crisis. Then there are secondary cytokine wave and a secondary cytokine crisis. First cytokine wave comes on day 3, sometimes day 2. And at that particular moment, if you miss the bus, you can end up into cytokine crisis. That missing the bus is day 5. The bus leaves on day 5, inflammation process starts. Then manifestation may come anytime. So by day 5 and day 3, between day 3 and day 5, if there is a doubling of C-reactive protein, these are the patients who should be given steroids and anticoagulation immediately.
Right.
All our doctors who are dying in India, we have found out that they are missing day 3, day 4, and day 5.
Sorry,
Right.
the president.
Yes.
I just missed your points just now. You said that with a loss of taste or smell, together with 3 more symptoms,
No,
suspicious
no.
of what?
I said in today's scenario, new onset of loss of smell and taste is itself sufficient to diagnose COVID in the current scenario. Okay, in the current scenario, though there can be other causes of loss of smell and taste, but in the current scenario, in situations where the disease is, where there is a community spread, where the incidence of prevalence of COVID is more than 5%, their new onset of loss of smell and taste should be presumed to be corona positive unless proved otherwise. Apart from that, if you get any other 3 symptoms from corona-like illness, then you should presume that to be COVID. That's fever, sore throat, that can be a dry cough, breathlessness, abdominal symptoms, ear symptoms, and muscle symptoms.
Even without loss of taste or loss of...
I'm saying, yes, without loss of, if the loss of smell and loss of taste is there, you don't have to bother about other symptoms. Without loss of smell and taste, any combination of 3 symptoms, you should suspect, say, corona, unless proved otherwise.
But the flu epidemic is also coming in Hong Kong and other places
So
in
in
USA.
flu, the fever will always be more than 100.4. In corona, the fever is less than 100.1 to start with. In corona, if the fever is more than 100.4, take it for granted it's pneumonia and it's already a cytokine wave. In flu, you will predominantly have nasal symptoms, and here you will have predominantly throat symptoms. Nasal discharge will be very less in corona, will be very high in flu. Okay, and doubling of CRP on day 3 and day 5 will be much common in corona than in flu. But sometimes it is very difficult to differentiate.
So it should be suspected. It should be suspected and tested in that case.
What I'm saying is, what we are seeing in India is people are waiting for
Okay.
the thief to be caught. People are waiting for the thief to be caught. That means they are all the time bothered about whether it is corona or flu. Treat the patient. If you don't treat the patient may become serious.
Yes, agreed. Yes.
See, recently we lost one lady in the city. Her husband was positive. She was symptomatic, and because she was having fever, the report came negative. So she started assuming that I am negative. And because the typhoid antigen was positive, they ignored for 5 days, ended up into a cytokine crisis and died.
Yes, I agree. However, I think we must raise our level of suspicion because almost 1/3 or half of the patients could be asymptomatic or with atypical symptoms like a rash, abdominal pain. And so I think as the president said, if there is a loss of taste and smell, that is quite specific, and we should really test for the COVID immediately, and I probably have to quarantine. Yeah, but for the other symptoms, also raise our index of suspicion.
So, Alvin, whether you have fever because of flu or corona, you have to quarantine. Both requires quarantine. And by that time you go, both requires isolation. On day 3 and day 5, you get your CRP done. And if the CRP is rising, you need to treat whether it is flu or whether it is not flu. You need to treat a rising CRP. If you have an evidence of a cytokine being released, why should CRP be high in absence of a bacterial infection and injury? The only thing which can increase CRP is a cytokine. So whether it is flu cytokine or corona cytokine, treatment is the same. So if you have an evidence of cytokine release, so there are 2 types of cytokines, bad cytokines and good cytokines. Good cytokine is IL-10. Bad cytokine is IL-1B, which causes fever and which increases ferritin. And we have IL-6, which causes temperature through hypothalamus. And so when we know there are bad cytokines releasing in the body, which is evident by CRP, what are we waiting for? What are we waiting for? How does it matter whether it is which infection? So I am only trying to draw a conclusion is why are all of us bothered about test is negative or positive? I say cytokines release have started, attack them. Once the cytokine release phenomena has started in the body, CRP cannot rise, cannot double. It can rise in diabetes, it can rise in obesity, it can rise with stress, but it cannot double in 24 hours in absence of cytokine release. That's what I'm saying. And the cytokine release test is C-reactive protein. Now, why not IL-6? IL-6 is more sensitive, but it is dependent on the way test is done. The sample has to be transported as a frozen sample. The test has to be done within 1 day. All IL-6 reports are coming to us after 3 days. How can they be reliable? If the test is not done in the first day, the test cannot be reliable. So therefore, now we are relying more on C-reactive protein in resource-limited countries. Now, Singapore and Hong Kong are resource-rich countries. They will rely more on IL-6. We will rely more on C-reactive protein.
Well, even in the commercial setting, I think the private doctors in Hong Kong could not really have access to testing IL-6 in the commercial laboratories. Of course, in the government labs, they could test for IL-6, I think.
C-reactive protein is a simple test. CRP more than 6 or less than 6 causes only 8 rupees. That is 10 cents of 10 US cents. If it is
Yeah.
less than 6 or more than 6, reactive and positive is only 8 rupees. Quantitative CRP costs only 200 rupees in India, which is how much it turned out to be $2 in India, $2 US in India, or $3 US in India. It's a cheap test. IL-6 on the contrary costs 4,000 rupees, which turns out to be $40. So
Yeah.
therefore, you can't do it every day. C-reactive protein. So my recommendation on behalf of CMAO is between day 3 and day 5. Between day 3 and day 5, if you demonstrate doubling of CRP value, it indicates cytokine wave. The cytokines have started in the body. Attack them before they go into a stop.
Right. Whether it's COVID-19 or influenza, this
How does
kills
it
the
matter?
patient
I said,
anyway.
it can be anything. It can be COVID-19, it can be COVID-20, 21. How do you know? How do you know a new virus coming in? So we are now, instead of going into virus, we are going into the pathology. That between day 3 and day 5, if you see doubling of CRP, the CRP has a half-life of 8 hours. Okay, so it will double in 8 hours. We are giving 48 hours to double. Normally, it should double within 8 hours. The doubling time of C-reactive protein is 8 hours. So therefore, we are saying between day 3, when is on initiation of cytokine wave, in the next 48 hours, if you can demonstrate a doubling of CRP, that's a sign that the cytokine waves have started in the body, inflammation have started. If you, at that particular moment, suppress the inflammation, things may change.
Hi, the President. I like to ask why is the topic today forecast in the notice is all about masking. So you want to talk about something about masking?
Yes, I'm coming to that now. Now in masking, what we are talking about masking is that we have tested in the market. Most of the masks available today are not reliable. Okay, so in masking, we should test two things. One is called as a splash resistance, and second is called as a breathability. Now, what is a splash resistance? The splash resistance is when I'm wearing this mask. So I'm wearing this mask. Okay, so my blood pressure is 120 millimeter of mercury. So the WHO says from a distance of 30 centimeter, if I splash with a syringe blood on this particular movement, it should not be soaked. It should go down and it should not stuck here. So blood thrown from a distance of 30 centimeter or any liquid, whether it is water, from a distance of 30 centimeter, if it is splashed over my mask, it should split away. So the outer layer has to be water resistant. And then how do you check? This is called splash resistance, and it should be, according to WHO, more than the blood pressure. Because when you puncture a artery, whenever you are, by mistake, if you are drawing blood, if you puncture a artery, the blood comes to your face with a speed of 120 millimeter of mercury. So the guidelines international are splash resistance should be more than 120 millimeter of mercury. So I have picked up around 15-20 masks from the city, and I put them from a syringe. When I'm putting them a splash of water, the water is coming here. And then I took the mask like this, and I put water here. I can see the water coming down. So the splash resistance, if defective, it is not going to prevent you. So whichever mask you use, according to IONESH, according to all the parameters, the splash resistance should be more than 120 millimeter of mercury. Now, if the splash resistance is high, then your breathability reduces. So breathability, there are indirect tests, but breathability should be less than 49 Pascal per centimeter square. That has to be tested in a lab, breathability. So breathability, you can test by yourself by finding out whether whether the light can cross or not in that particular thing. But in masking, in an N95 mask, there are 5 layers, and in a non-N95 mask, there are 3 layers. Now here I will show you. Now when I cut this mask, there are 3 technologies used to prepare a mask. There are 3 layers. So there are 3 layers of mask. This is layer 1, which should be water resistant. This should have a splash resistance of 120 millimeter of mercury. Then there is an inner layer, which should have a water absorbent. It should not have splash resistance. And this is the middle layer, which is the most important. Now, this is the middle layer, which is most important, which is a melt blown. That means the polypropylene should be melted and then converted into a paper. And if it is not melted and converted into this, the breathing efficiency will change. Now, cotton breathing efficiency is 17%, gauze is 3%. Surgical mask, it should be filtrability efficiency should be 99% for 3 micron, and it should be more than 80% for 0.3 micron. And for N95, this should be 95%. And for N99, this should be N99%. So the difference between a good mask and a bad mask is how many layers of melt blown they have. So if I use 2 melt blown, that means 2 filtration paper, this efficiency from 80 will become 85. It may become 89. So what I'm trying to say is, what I wanted to bring today was that the guidelines, these are not my guidelines, but none of us have talked about it so far. So I thought of discussing this, that 3 layers needs testing. So there has to be a country-specific guidelines. In India, we have CITRA, S-I-T-R-A, CITRA guidelines. In all other countries, this is NIOSH, N-I-O-S-H, N-I-A, whatever is that. So therefore, there should be 3 different types of clothes. All clothes are made of polypropylene, but with different technologies. This is called melt blown. Melt means you melt the whole polyper and converted it into a paper. This is spun. Spun means you use the polymers and without melting them, you make them into a paper. So therefore you can see inside, you can see the particles of the polypropylene. So the only thing which I am trying to say is that if the only way to prevent this disease is masking, as far as the Argentinian ship study has shown, that if everybody is using a surgical mask, either you will not get a disease. If you get, it will be mild. But then has to be modified that if you are using a proper mask. So it has to be, so we are up till now we are saying is consistent and correct. This is what the methodology is, consistent and correct use of mask. I am changing it to consistent, correct, and proper mask. Whichever you decide, mask should have a splash resistance. Otherwise, the secretions will cross through. Dr. Elvin.
Yes, thank you very much, Dr. Garo, for the very informative analysis of the makeup of the mask. I think it is very important Say, for example, you had highlight the importance of the middle layer of the melt and blown material, and then also the front cover layer that has to be resistant to the splash of 1.2 millimeter mercury, and that is quite, of course, important. But when we are having masks in Hong Kong, very often they are only selling the level one surgical mask, and sometimes they could not fulfill the protection requirement of the splash by blood, and some perhaps fail in the filtration ability of the middle layer. But at least I think level one is something that we can use for the citizens. But I guess for medical practitioners to protect ourselves, we better use at least level 2 or level 3. That is all the functions of the mask that have been described by the president have to be present. Then that will safely protect, more safely. I mean, of course, if we use N95, we also need to do the fitting test for the N95. If it's not fitting to our face, there will be gap between the mask and the face, then that defeats the purpose. But that is more for airborne infectious diseases rather than the droplet spread infectious diseases. For droplet spread diseases like COVID-19, perhaps surgical masks suffice to protect us. So using N95 fitting well masks could produce poor ventilation, and so hyper carbon dioxide and less oxygen in the air between the mask and the nose, and that could sometimes cause some hypoxia and even fainting if we had put it on for a long time. So I think for our usual practice, we put on this correct, proper surgical mask. But if we are working in the ICU or infectious disease unit in isolation wards, then we have, or doing the aerosol producing procedures, then we have to use the N95 mask. And I'd just like to raise your concern about sometimes the celebrities, they have been a very bad example on putting on masks and demasking. Just like recently, Donald Trump, when he recovered and left the hospital and returned to the White House, he just took off the mask and then with his hands and then put into his pocket. And the same was practiced by his physician in charge, that Dr. John Conley. Yeah, he also just in front of the cameras in the press conference, took away the mask with his hands and then put into his pocket. And after that, after finished talking, he took the mask from his pocket and put on the face again without any sanitization of his fingers and hands. I think that is a big loophole in our own protection, because with our hands touching the mask, our hands would be contaminated by the virus in the droplets on the mask. And then we put it into the pocket, it contaminated the pockets. And then when we use the fingers to touch our eyes and nose again, we got infected if there were viruses there. So, and I think that is a negative example. And however, I think many people had not noticed it. And we just, the citizens just kept on the wrong way of handling or touching or demasking our masks, then I think this needs education as well.
Now,
Thank you. That's what
Mr.
agree.
President,
I just
I
want
think
I just
most
want to
of-
finish one, Dr. Sajjad. I want
no,
just
no,
to
I just endorse. Sorry, you want to say something?
no, go ahead, go ahead.
Okay, I just endorsed Dr. Alvin, and I say that everybody is noticed, but wrongly noticed, and the people will follow the same what the President of America and his physician did. That you can put your, you can just remove your mask and just put it on your pocket or anywhere, and just you can use again the same mask. So this is the wrong message going on everywhere. So this is the fact. But one more question, Mr. President, I would like to ask for my information, that how can you handle in education in a primary children to wear the mask? It's very difficult to
So,
wear mask in a small children like primary school. So in Pakistan, the teachers are giving punishment to wear the mask every time. So it is not possible for a younger.
this matter should be taken up by Pakistan Medical Association. Children less than 5 years, no masking is required. Between 5 and 12 years, we need to educate them and not punish them. And that is between the WHO says between 5 and 12 years, it is not possible for the children to behave. So therefore, just educate them, don't punish them. Try to teach them. It's a decision, but after 12 years, it's mandatory. So though no punishment less than 12 years, Pakistan Medical Association should take it up and write it down. So I
Yes,
just want to agree.
We are doing this. I'm doing the same thing. Okay, thank you.
Very good. I just want to say the color does not mean it's surgical. That's my sentence. Because the coloring does not mean, because if you see this mask, which actually I was wearing till a week back, when I was not knowing all this splash resistance and all, I put water, it started leaking. Then I cut open and I saw that the outer layer and the inner layer cloth is the same. And the middle layer, I can see through the middle layer. If you see the middle layer, I can see through. So this is not a melt blown. This is again a spun bound technology they have used. And I can see here, if you see here, you can see through it. And here actual mask, you cannot see through. This is what a splash resistance, a good splash resistance would mean. You cannot see through. Can you see through compared to the other one? See, this you can compare. They are two different things. So this is what I'm trying to say is that in India, we are losing so many doctors. We are getting infections. One of the reasons will be we are not using a correct mask.
Okay, one point I want to bring in is that even the tying the mask
Yes, that's
behind
okay.
your
That's
head
all.
and the ear loop, tying the mask behind the head makes it a little more sort of tight
Yes,
enough
absolutely.
to prevent bacteria and dust coming in. Another thing is to what extent you promote wearing a shield along with the mask, particularly among health
I went
workers.
to the WHO and CDC. They says if you wear it over a mask, it's okay, but not as a replacement of mask.
Okay.
It's an extra protection to the eyes, but it is not a replacement for the mask. Okay, then I'll request Professor Jayalal to give final comments. And congratulations again. Welcome to the Simao family officially. And give your final comments and then we disperse for next week.
Thank you very much, sir. It is a great pleasure for me to be with you. I think the amount of pain you are taking to disseminate the knowledge and appropriate and the correct knowledge on this COVID era is something phenomenal. I think you are a record holder and holding more than 1,000 meeting, nearly 1,000 meeting, and training not only the top level doctors, the association leaders, but also to the common level public that you are able to do that. And that is a great job. And one of the important things that you talked is the masking, is really masking the people from with the false security. And the way you have explained the details is a real eye opener for many of us. I'm sure that every one of us would try to take this as an important priority agenda. So because it is going to, the COVID is going to stay with us for some more time. And only weapon we have to prevent this is the appropriate masking technique, and the masking, made it available. And in India, especially the Indian Medical Association has had a very great deal with the 3M company, and with a very cheap nominal price that we are making it available to the entire medical fraternity in India. And millions of masks were purchased by our doctors, and that is a great service the IMA has done to the medical fraternity. And addition to that, how to wear it and what are the nuances on that will be also to disseminate it to our members. I'm sure that our good effort will definitely pave way for us to see that control and drastic control of this pandemic in the days to come. Thank you very much for your enthusiastic effort in this process of propagating this good message, sir. Thank you, sir.
So thank you, everybody. We'll be back next week on Saturday.
Okay, thank you very much.
Thank you.